Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Sarah Anderson. Today's episode features content from an educational program titled Contemporary Management of HIV 2021. During this podcast, Dr. Geeta Gupta, Professor, University of California, Irvine, and Director, AIDS Education and Training Center, discusses ART management in heavily treatment-experienced patients. For more information about Dr. Gupta and for a link to the full online educational program, including downloadable slides specific to today's podcast, please visit the link in the show notes for today's episode. Now, let's get started and hear what Dr. Gupta has to say about ART management in heavily treatment-experienced patients.
In this case, the patient had a high viral load. A genotypic test was done. And we see that you can see in all PI, NRTI, NNRTI, and integrase, there are a lot of mutations. And a tropism test was done, and now he has dual mixed virus. So a phenotypic test here, we don't have results for. However, how to interpret all these different mutations can also be done through the Stanford Database Resistance Interpretation website. And that's HIVDB at stanford.edu. And you can see here, as we could have, for those of us who are knowledgeable about these mutations, it confirms what we thought is that this patient has a lot of resistance. All the NRTIs, all the NNRTIs. Darunavir, ritonavir had some intermediate resistance. Otherwise, the PIs are resistant, and the integrase inhibitors also have resistance. So how do you manage this? Well, this chart is taken from the DHH guidelines, but honestly, it doesn't tell us anything earth-shattering. Basically, it says, and you can see the right-handed box, you want to try to get 2 and preferably 3 fully active drugs. That's the bottom line. And so how do we do that? We, from an older study, it was one of the early raltegravir studies done in resistant patients called the BENCHMRK. Patients were given OBT, which means, and that comes up again and again, stands for optimized background therapy. And that generally means is based on resistance tests, you choose your antivirals that had still sensitivity to them. So in here are treatment experienced patients with resistance. They looked at the success of therapy of getting to an undetectable viral load by the GSS score, the genotypic sensitivity score. How many drugs on those resistance assays were deemed sensitive? So in those patients who had none, the raltegravir arm plus optimized background therapy, only 45% success. When you had one drug, then you're adding raltegravir as the second drug. So now you have 2 sensitive drugs. It was 67%. And if you had 2 or more drugs, you add raltegravir. So now you have 3 fully active agents, 75%. The phenotypic score had the same results. So there wasn't any added benefit really from the phenotypic score. But having 2 agents, we can see here, 2 fully active agents really gives our patients a good chance. So when we're looking for drugs, we, as I mentioned, new drugs with a novel mechanism of action and no cross-resistance, our patient's virus will be sensitive to. And we'll talk about 2 such drugs, ibalizumab and fostemsavir, the newest drugs that have come to market with new mechanisms of action. And then there's the possibility of using drugs that you've used before or in existing drug classes that have been used before. So first, let's talk about ibalizumab and fostemsavir. So ibalizumab was FDA approved in 2018. It is a monoclonal antibody that binds to the CD4 receptor, and it blocks viral entry by preventing and changing that GP20 CD4 complex. It was studied in this particular study. This is what got it FDA approval. And these were patients with multidrug-resistant virus. They had to be sensitive to at least one existing antiviral in order to be put into the study. And it was a one-arm study. They started off adding the ibalizumab to whatever the failing regimen was, just to see what sort of potency it had on its own. And then it switched to the optimized background, now R stands for regimen, and continuing the ibalizumab. Remember, ibalizumab, monoclonal antibody, delivered by IV infusion every 2 weeks. These were patients. The mean viral load was 4.5, and you can see the CD4 count here, 150 cells. So these were advanced patients. And the outcomes through 96 weeks here, you can see that the primary outcome, which was, how many patients had a viral load decline of at least a half a log by day 14. So after that first infusion, and it was 83%. And then going to the next triangle, how many patients ended up with an undetectable viral load as you went on? And you can see that it was over 50% in these patients with highly resistant virus that otherwise we had nothing for. Safety of ibalizumab seems to be pretty good. You can see here the table as patients remained on the therapy for 96 weeks. No new safety signals emerged. And the CD4 had a modest increase over time. So the FDA, again, only recommends this. The indication is its use in highly resistant virus and for patients who then have very extremely limited treatment options. Again, it's difficult to administer, as every 2 weeks you have to give that IV infusion. Although people have also said that when patients come in every 2 weeks, you can also help boost their adherence for the rest of their drugs also. So there's a good aspect of that and a bad aspect of that in this type of a patient. Now, the other drug that we'll talk about, a new drug or a newer drug, is fostemsavir. Fostemsavir is a prodrug of temsavir, which is the active metabolite. It binds to the glycoprotein 120. So in doing that, it also changes and blocks the conformational changes that need to occur between the CD4 receptor and GP120. So it too is a viral entry inhibitor. This drug also was studied in highly resistant virus. Here's the study that got it the FDA approval. There were 2 sections to the study, the randomized cohort and the non-randomized. The randomized cohort, these were patients who at least had, again, one fully active approved agent. And then fostemsavir would be added to it. Initially, fostemsavir versus a placebo was added to the failing regimen, just again to see what the potency of this drug is on its own. And we saw basically a 0.8 log decline. So it's a medium potency drug. It's not a low potency drug. After the initial randomization, everyone was put on fostemsavir, and this is a BID drug. It is oral, plus optimized background therapy. The drugs were chosen by the results of resistance assays. The non-randomized cohort was just a single arm. Everybody got the fostemsavir and the optimized background therapy from day one. And the way it was different in the type of patients is that these were patients who had no remaining antiviral classes left, no fully active approved agents. So their GSS or PSS score would be 0. In the optimized background therapy, other investigational agents were also allowed. So when we look at the results of who got to undetectable, in the randomized cohort, we see somewhat better results than the non-randomized, and these were patients that had more options. So this is what we would expect. And up to 60% of patients got to undetectable, highly resistant patients. So these 2 drugs are really helpful for us in treating these patients. And when it came to safety, this drug was well tolerated. The few deaths that did occur were generally due to AIDS-related illnesses, not to drug, although there was one that was thought to be due to virus. Additionally, CD4 counts increased quite a bit in the non-randomized cohort, about 200. and about over 100 in the non-randomized cohort. And what your baseline CD4 count on the right-hand side didn't seem to matter. Everyone got an increase, a bump in CD4 count, and the lowest was at 172 to 240. So that's a pretty robust increase in CD4. So the key takeaways in fostemsavir, again, it's FDA approved for patients with limited treatment options due to resistance or other things. Actually, the DHHS guidelines have not even really included fostemsavir yet, but the IAS guidelines have. We'll see as time goes forward and more studies are done for its use in less resistant patients. Let's put it that way.
Great. Thank you very much to Dr. Gupta, and thanks to our listeners for joining in. As a reminder, to view the full educational program, Contemporary Management of HIV 2021, on the Clinical Care Options website, click on the link in the show notes for this episode. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.